Friends, this is a hypermature Morgagnian cataract in a 80 years old male. I have taken up this case for surgery. Let us see how the surgery went on. This is the main incision. It's a 2.8 millimeter incision at around 11 o'clock. Now, a side port is made about 2.5 clock hours away or 3 clock hours away from the main incision at around 2 o'clock. Now the anterior capsule is stained underneath this air bubble. Trypan blue dye 0.06% is injected underneath this air bubble. It is swept all around so that there is uniform staining of the capsule. Now the dye is washed out. Little bit staining is enough. You need just a little contrast to do the capsulorhexis. Now this is HPMC, hydroxypropyl methyl cellulose. Now I'm doing capsulorhexis. Now I see as I make a puncture at the center of the capsule, anterior capsule, and as I enlarge, try to do orhexis, see what happens. Lot of milky fluid comes out, indicating this is a hypermature Morgagnian cataract. In Morgagnian cataracts, you can aspirate the milky fluid at this point. This puncture site will not extend. Now inject viscoelastic substance. In this case, I am doing rhexis at one go. I'm going to spiral this small rhexis and going to do an optimum sized rhexis. That's it. The capsulorhexis is done. And now we know that there is no support of epinucleus. There is no epinuclear shell to support the nucleus. The epinucleus, cortex, everything has melted and it became milky fluid which has partly come out. So I have to be very cautious in managing this nucleus. So I stable the nucleus with vacuum and I'm doing horizontal job. This nuclear piece became free and I emulsified it and removed, holding it at another place, and this is another job. This portion of the nucleus, a bigger piece, is emulsified and removed. I am keeping an eye on the posterior capsule, whether it is floppy or not, whether it tends to come out or not. Now I am trying to chop this bigger half, and I'm just positioning the piece in such a way that the equatorial part of this piece supports the posterior capsule. However, the chamber is very stable and the posterior capsule is far behind. Frequently, I am removing the chopper to prevent leakage from the side port, and very safely the nucleus is managed. Now we can see that there is no epinucleus. Very little cortical matter is there. So I just use Simcoe cannula to remove some fibers here and there. And after removing these fibers with Simcoe cannula, I do a little more polish with the irrigating probe of the bimanual IA. Still, I am using the Simcoe cannula. This instrument is looked down upon by many surgeons, but it is a fantastic instrument. Now this is the irrigating probe of bimanual IA, and I am doing hydro polish. Just using the jet of fluid to polish the posterior capsule. And now I'm implanting a hydrophilic acrylic intraocular lens under this irrigating fluid. This irrigating fluid keeps the anterior chamber formed, and this beautiful lens is placed in the capsular bag. Now we have saved a lot of time because we have not used viscoelastic substance to implant the intraocular lens. If you use viscoelastic substance to implant the intraocular lens, you have to give a lot of time, at least 1.5 minutes to 2 minutes, to clean the viscoelastic substance out of the anterior chamber and from the capsular bag. Some more fibers were seen inferiorly at 6 o'clock, so I'm removing those fibers again with the Simcoe cannula. This is moxifloxacin. And now there is only one side port in this case, and I am hydrating the side port. That's it. The case is done. You just have to give a final wash. This is a view under higher magnification, and this is the final wash. That's it. You just have to form the anterior chamber and conclude the case. Hope this video will help you in managing your Morgagnonian cataracts. Thank you very much for your attention. Thank you once again.